How is endometriosis diagnosed? I don't want to do surgery. Initially, it was believed that laparoscopy was the only way to diagnose endometriosis. I had a teacher of mine who was a very, very famous endometriosis surgeon who in the 90s and the early 2000s would say, I don't need ultrasound, I'll put the laparoscope in and figure it out. This is no longer true. You don't need to put in a laparoscope to diagnose anything. We have such good imaging modalities. And the most important tool for diagnosis is just your 2 ears. You have to listen to your patient. The patient will give you a history and tell you exactly where their disease is. Imaging modalities like ultrasound and MRI are very, very effective at picking up most disease. But this is heavily operator dependent, which means who is performing the ultrasound and who is reading the MRI. Most ultrasound scans will only look at the uterus and the ovaries. But there is a particular protocol for endometriosis mapping, which not only looks at the uterus and the ovaries, but it also looks at the bladder above, the ureters, which drain from the kidneys into the bladder. And also they look at the bowel and the pelvic side walls where the nerves run along. Furthermore, we look at the movements of these compartments in relation to each other. So we're able to tell if something is stuck, we're able to tell if something is adherent, we're able to tell if disease is growing into a particular organ or not. And this is going to make a much more accurate diagnosis than a standard ultrasound, what is done by general sonologists and radiologists. Even for the MRI, the ability to read the MRI is very different between specialists versus generalists. So it's very important to set those two apart. There are numerous papers coming out now defining set protocols and the way imaging for endometriosis has to be reported. So we're trying to universalize the language of this disease so there is no ambiguity between diagnosis and treatment. So there are 3 types of endometriosis. One, which most people are familiar with, are the chocolate cysts. Those are the easiest to diagnose because they're large and they have a very, very particular appearance. And most radiologists are able to diagnose this very easily. The other 2 are the deep endometriosis, which are lesions which are 5 millimeters or larger in size, so basically deep infiltrating disease. And the third is superficial peritoneal disease, which cannot usually be picked up on imaging. Now, all 3 subtypes usually exist together. So the first misnomer is if you think you only have a chocolate cyst, you're dead wrong. But if a surgeon has scheduled surgery only to perform a cyst removal, they have no idea what they're doing because a cyst never exists by itself. It's always accompanied by deep disease or peritoneal disease, or usually a combination of all 3. So an experienced endometriosis specialist will look beyond the cyst and remove all 3 things, which really lowers the recurrence rates and definitely improves pain scores and outcomes. Laparoscopy is never used as a sole diagnostic tool. It is a fool's errand to say, I'm going to put in a laparoscope and figure out what I'm going to do after that. We have to use the imaging to figure out the deep disease. Of course, the laparoscopy is going to help you identify superficial disease, which you're also going to take out. But the corollary is, for someone with early stage disease who has only peritoneal disease, which may not pick up imaging, so imaging doesn't rule out the diagnosis of endometriosis. In those very particular small subset of patients, a laparoscopy, not only to diagnose, but also to excise the peritoneal disease at the same time, may be indicated in them. Now, if you've received a diagnosis that you may need surgery, nobody wants to undergo surgery. Even as a surgeon myself, if somebody told me I needed surgery, I would think about 100 times before going under the knife. It's very important to understand that not all surgeries are urgent. There are options of waiting and keeping it under observation. And as any good practitioner, I think this should be presented to the patient. In endometriosis, there are usually only 3 or 4 situations that require urgent surgery. One of them is if there is a large nodule in the intestine, which is going to cause a block of the intestine, which obviously needs urgent surgery because it's life-saving. Or if there is a lateral nodule, which is compromising the ureter and further damaging the kidney, we need to operate to be able to save that kidney. Or if there is a very large cyst that is going to possibly grow in size and cause detriment to fertility, then sooner rather than later is important in terms of fertility preservation. As we've stated before many times, the diagnosis of endometriosis has a tremendously long journey. Most patients take 7 to 10 years to receive a diagnosis. They have multiple misdiagnoses, multiple treatments, even incomplete surgeries prior to getting a proper diagnosis. Ideally, moving forward, with more awareness about this disease, we want to shorten that diagnostic period by recognizing endometriosis-specific centers of excellence, whether it's primary care, or secondary care, so as in the general or family practitioner, or the general gynecologist who says, okay, this could be endometriosis, I need to refer this patient to someone who knows what they're doing, to help shorten that diagnostic delay and to expedite them getting a correct treatment.